Abdominal ultrasound can be challenging and often feels daunting to the inexperienced user. The difficulties are worsened by poorly prepared patients with challenging body habitus, bowel gas, and poor positioning. However, it may be useful for a broad range of different pathology, provided the clinician approaches the assessment with a clear question in mind, guided by conventional clinical history and examination. Remember, we are not trying to replace, nor would we have time to replace, the comprehensive, full system interrogation performed by sonographers or radiologists. Abdominal ultrasound requires use of the low-frequency curvilinear probe, which provides optimal tissue penetration at the expense of resolution. A phased array or microconvex probe can be used if a small imaging footprint is required. This slide demonstrates the probe position for the regularly performed point-of-care ultrasound exams. Most accreditation pathways focus on the identification of free fluid in the abdomen using the right upper quadrant, left upper quadrant, and pelvic windows. The renal tract is simply an extension of these windows. Although the abdominal aorta is not strictly part of the FUSIC or famous curriculum, it is an important abdominal landmark and a potentially crucial cause of hypotension in a patient with undifferentiated shock. The inferior vena cava lies to the right-hand side of the abdominal aorta and is frequently assessed as part of an echo study and so will not be discussed here. The right upper quadrant is the most common initial window to acquire and may demonstrate free fluid in up to 66% of positive FAST exams. The probe is placed in the right flank in the sagittal plane with a probe marker pointing cranially. From this position, the probe may be rotated to lie parallel to the ribs to reduce acoustic shadow artifact obscuring the image. In this view, the liver is the dominant structure and is bordered cranially by the diaphragm and caudally by a hyperechoic layer of perinephric fat known as Morrison's pouch. In the absence of pleural fluid, there may be mirror image artifact of the liver on the opposite side of the diaphragm, which is a normal finding. You should fan through the image to interrogate all potential spaces where fluid may accumulate. The inferior border of the liver is a location where fluid is frequently missed because of incomplete visualization. Free fluid can accumulate in any tissue plane and often appears angular compared with the fluid located in hollow viscera. These images are examples of free fluid seen within Morrison's pouch. Note the anechoic stripe seen between the liver and the kidney. The left upper quadrant window may be more challenging to optimize due to the relatively small size of the spleen, and a more posterior approach is usually required. The probe is placed in the left flank in the sagittal plane with a probe marker pointing cranially. Once again, this may be optimized by rotating the probe to be parallel with the ribs. The image generated is similar to the right upper quadrant, with the spleen bordered by the diaphragm cranially and the splenorenal recess caudally, with the left kidney forming the lower border of the image. Again, the user must fan through all areas of this image, paying particular attention to the region between the spleen and the diaphragm, and the inferior border of the kidney. These images are two more examples showing free fluid in the left upper quadrant view. The pelvic views are required by placing the probe superior to the pubic symphysis, and will need to be angled caudally to identify pelvic organs. A transverse view is routinely performed first, with the probe marker pointing to the patient's right. The major acoustic window in the pelvic view is the fluid-filled bladder. An empty bladder may make clear delineation of structures really challenging. Furthermore, acoustic enhancement posterior to a full bladder may result in deeper structures appearing more echogenic and therefore brighter on the image. The longitudinal view is acquired in the abdominal midline with the probe marker pointing cranially. Again, it is important to remember that a still image is insufficient to exclude pelvic fluid, and the user should try to systematically fan through whatever structures are identified. Key anatomy in normal individuals will evidently vary depending on the gender of the patient. In males, the small bowel is identified superficially with the bladder and rectum posteriorly. The prostate and seminal vesicles can be seen behind the bladder. In females, the uterus lies cranially to the bladder, with the vagina behind the posterior bladder wall. Pelvic fluid will typically accumulate first in the rectovesical space or the pouch of Douglas, and may be challenging to identify in suboptimal conditions. A small volume of fluid in the pouch of Douglas can be a normal finding during ovulation. Fast scanning, or focus assessment with sonography in trauma, is an algorithm that encompasses these windows to identify free fluid in patients who have sustained abdominal trauma. Following trauma, any free fluid is assumed to be blood, but of course any fluid can lead to a positive scan. The extended fast, or EFAST, includes interrogation of the pericardial and pleural spaces to exclude hemorrhage within these areas. The role of ultrasound in trauma has largely been superseded by protocolized trauma CT imaging in major trauma centres, but may still play a role in more resource-limited settings. FAST has, however, introduced point-of-care ultrasound to clinicians working in time-critical scenarios, and has been built upon to create protocols for other clinical states, such as a rush protocol, or the rapid ultrasound for shock and hypotension. This protocol only takes several minutes to perform and combines echo, thoracic, abdominal and vascular ultrasound to provide rapid information in patients with undifferentiated shock. Ascites is a common clinical finding and appears as a homogeneous, anechoic collection. Acidic fluid with a volume as little as 5 to 10 mL may be identified using ultrasound. Measurement of the depth of ascites may reassure the clinician prior to performing any intervention. Paracentesis is classically performed within the right or left iliac fossa. An ultrasound may be placed here in an oblique view after the patient has been positioned. As mentioned, the depth can be measured using calipers, with the deepest point being marked. Similarly, the distance between the probe and the abdominal cavity can be measured to estimate the distance the needle should be inserted prior to expecting to aspirate acidic fluid. If minimal fluid is present, the linear probe may be used to guide the needle insertion in a similar way to ultrasound-guided vascular access.